Okay, hi everyone. Sorry for the slight delay. We were just getting the slides sorted. Um, can you see us now? Okay, great. Okay. So today we've got with us Dr. Claire Anderson, who's very kindly agreed to do this talk. She's a haematology registrar at Great Ormond Street Hospital, and we're presenting on sickle cell disease. I just wanted to say just now that we will have like a feedback form at the end, and if you complete that, then you'll be able to get a certificate and everything. So I'll post a link at the end so that you can access that easily, but I think it will also be emailed to you. Okay, so I'm going to stick around because I've got control of the slides, I think, but I'm going to hand over to Claire to give the talk.
Thank you very much, Sarah, for the introduction, and good evening, everybody. Real apologies for the slight technical delay that's delayed our starting time, but hopefully we should get through everything. So, as Sarah was saying, I'm Claire. I'm one of the hemoglobin. I should start that again. I'm one of the haematology registrars at Great Ormond Street, and I'm just going to talk to you about sickle cell disease. So, go to my next slide. Really, sickle cell is I don't have any disclosures to disclose to you. And really, my aims and objectives are to give a broad overview of sickle cell disease. It's a massive topic, but I thought it's important if we just touch upon some really common scenarios that you will see in clinical practice and just go through the complications. I will describe the pathophysiology that underpins sickle cell and then illustrate some of the clinical management aspects with some case studies, going through typical acute and chronic complications, but also childhood-specific aspects and pregnancy considerations. So, sickle cell disease, it's the most common genetic disease worldwide and affects persons of African heritage. It's estimated now that between 12,500 to 15,000 people in the UK live with sickle cell disease, but that's likely an underestimate. With the diaspora of people from Africa all over the globe, and in addition, more people immigrating from countries where sickle cell is more prevalent, we will see an increase of people with sickle cell in the United Kingdom. So, the genetics of sickle cell is that in order to have a sickle cell disease, you inherit the sickle hemoglobin with another sickling hemoglobin or beta thalassemia mutation. So that could be either deletion or a non-transcriptional thalassemic hemoglobin. So in sickle cell disease, there's a point mutation at position 7 with glutamate replaced by valine. Just to note that they've changed the nomenclature of naming the amino acids. So a lot of the textbooks say position 6 is where the amino acid changes, but after renaming to include the methionine residue, it's now position 7. The most other common hemoglobin, sickling hemoglobin that you encounter is hemoglobin C, where actually it's the same position in the beta gene, but instead of a glutamate being replaced by valine in HbSC, it's replaced by lysine. And then if you've got a sickle hemoglobin with a beta thalassemia, so that's either beta plus or beta 0, or one of the delta beta or the poor thalassemic hemoglobins, you will get that sickle cell disease. And then other more common in Asian and Middle Eastern populations, your D Punjab, O Arab, and E. So that's just the genetics. So in summary, you need a hemoglobin S with another sickling hemoglobin to have sickle cell disease. Sickle cell anemia is when you've got two S's. That's just a bit of the nomenclature. So in terms of the pathophysiology, so the cardinal feature of sickle cell disease is that this amino acid change means there's a non-polar pocket that forms. So when you have deoxygenation of the hemoglobin molecule, the polymers kind of shift to hide that pocket so as not to expose it because it's very hydrophobic. But while that process is happening, that leads to the cytoskeleton change and the sickling shape of the sickle cells. And that's why you then end up with vaso-occlusion, because the usual red cell shape is a biconcave shape, and that's to allow it to pass easily through small capillaries. And when it's got sickling happening within it, that leads to rigidness of that structure, so it can't easily pass through. That's why you get the vasoconstriction. Unfortunately, once the vasoconstriction sets in, that then cascades into endothelial damage. So you can imagine that you've got stasis here because of the vasoconstriction. That leads to a sterile inflammation with a non-infected infiltrate of white cells, releasing cytokines, which then attracts more white cells and platelets to that area. And then because the sickle cell, when it's got that sickling process, it's very fragile and liable to hemolysis. And when you have hemolysis, the free hemoglobin is usually scavenged. But when you've got hemolysis, you've got more free hemoglobin, which is actually quite toxic, and you get scavenging of nitric oxide. And what happens is that leads to even more vasoconstriction, and it dysregulates the endothelium. So in summary, you have vasoconstriction, you have sterile inflammation, you have endothelial damage and hemolysis, and those are the interplay of the pathophysiology that happens in sickle cell. And really, it's hard to predict how the patients behave, because some maybe have more a vaso-occlusive phenotype, others may have more hemolysis. And it's not well understood, but we know that modulators such as how much hemoglobin F can affect this, and if you co-inherit a G6P deficiency or an alpha trait, they play into it, but a lot of it's poorly understood. But there's quite a complex interplay in the pathophysiology. So just to really reiterate that sickle cell disease, although it causes anemia is just the tip of the iceberg. It really is a multi-system disorder. I mean, if you think about any organ in the body, there will be a factor in that system that is affected by sickle cell. So neurocognitive dysfunction is a major complication, and that could be more acute stroke. It could be ischemic or hemorrhagic in the acute setting, but also just cognitive decline, predisposed to retinopathy and retinal infarctions, and also hemoglobinopathy. And we worry about, in the acute setting, acute chest syndrome, where you actually have sickling in the lung parenchyma, and that's life-threatening. But in the long term, lung damage can lead to pulmonary hypertension. And then also these patients, if they have nocturnal hypoxia through other diseases or disorders, that can compound this effect. And then in the heart, the chronic anemia itself puts extra strain on the heart, and then they're also prone to diastolic heart function. In fact, pulmonary hypertension, this also interplays with cardiomegaly and cardiac dysfunction. Because of hemolysis, there is a tendency to develop pigmented gallstones. So they can present to the surgeon with acute cholecystitis or symptoms of biliary colic. Not to mention the liver itself can be prone to be affected in sickle cell. So really every system, renal dysfunction, anemia, infection, because of the fact that they have functional asplenia. Not to mention there's also thought to be some T-cell related dysfunction also, and it affects the GI system and the GU system. So women may have difficulties with conception or pregnancy related complications, which we'll get to in a case. And in men, priapism is a big concern, but after that subsides, some men are left with erectile dysfunction. So it really is a chronic disease with lots of complications. So as this slide illustrates, you will encounter patients with sickle cell in every specialty. So it's important to have awareness how to manage them and what to look out for. So now I'm just going to go through some case studies to just explain how we manage patients with sickle cell in acute settings, in outpatient, and then in the paediatric clinic, and then when they present to obs and gynae. So the first patient we're going to talk about, these are theoretical cases. So Kofi is a 21-year-old male with hemoglobin SS who's on hydroxycarbamide, or known as hydroxyurea, outside the UK. He's at university studying computer science, and he presents to A&E with severe back pain. So already in this context, we're alerted that he's got sickle cell, and we're wondering probably has a vaso-occlusive crisis. So these are my thoughts after we get his triage. So looking at the triage, he's afebrile, heart rate slightly elevated, but that could be due to pain, given that his pain score is 10, although blood pressure SATs are acceptable. He's very distressed, so we need to manage him. So these are the sort of things that I think about when I'm going to see a patient with sickle cell. So really, it is an ABCDE approach, and you have to summon help quickly. Could you just show the next slide, please? It's important to remember that these patients, you have to monitor them very closely. They have reduced physiological reserve and can decompensate, so it's important to make sure that they're on your radar. You need to treat pain as a medical emergency because it snowballs. For these patients, if they're in pain, they're not taking deep breaths, and then what can happen is that can then lead to acute test syndrome, which could be life-threatening. You need to be very vigilant, looking out for complications and critical warning signs. And it's really important to intervene early and aggressively and summon expertise with the haematology team. We want to know about these patients early so that we can arrange action, escalation to ITU if necessary. And it's important that we have as much notice as possible, because it's not always that straightforward in managing these patients. For example, some of our patients develop antibodies, so it may take quite a bit of time to get blood ready if they need a transfusion. So it's just these things to bear in mind, why to give as much notice as possible and to really intervene at an early stage to avoid decompensation. Next slide, please. So in an assessment, it's good to look at the patient's key record and clinic letters. You're really looking at previous sickle cell complications, the pertinent things to pick out really. What complications have they had? Do they have any other comorbidities, for example, asthma or PEs or anything else that could be affecting or compounding the sickle cell crisis? You want to know drug history. A lot of our patients with sickle cell in this country have travelled to Africa, so you need to still think about other general medical conditions and malaria in particular. It's important to know their baseline hemoglobin, renal function, and SATs and room air. And I cannot stress that it's really important to look at the vital signs. And then you really peruse the chart and scrutinise the critical warning signs and look at the specific complications. So just to go through the red flag things that should have your alarm bells ringing. So if the patients just seem generally unwell, they are unwell. And any abnormal chest findings, clinically you cannot distinguish between pneumonia and acute chest, so we just treat them the same. And desaturation is a cardinal worrisome sign really. So if the SATs are less than 94, or if it's a 4% change from baseline, as some of our patients may have chronic hypoxia, but it's really that change, or any focal signs, crackles, signs of pleural effusion, for example. Any cardiovascular instability, and if they have an anemia that's 20 grams below their baseline. I mean, these patients tend to be anemic. That's why we cannot rely on the lab normal reference ranges and interpret the hemoglobin in the context of the patient's hemoglobin and normal levels. Any acute neurological sign is worrying, severe pain, any fever, especially as they have functional asplenia due to autosplenectomy that happens fairly early on due to the cycling of sickling. Any surgical abdomen, they can get gallstones, but also they can get sickling in the gut and can actually develop ileus or any ischemic gut, so that's also worrying. And then an enlarged liver or spleen, because these are symptoms of sequestration, and that can be life-threatening because you're pooling of blood in the liver and spleen, and they can just have a shock and collapse right in front of you very, very quickly. So the management of vaso-occlusive crisis, this is probably the most common presentation that you will encounter in your clinical practice. It's really important to get pain relief within 30 minutes, and your goal is to try and get the pain controllable within 2 hours. A lot of sickle cell patients have an individual pain plan, and it's important to note that it may seem that they're on high doses of opioids, but that's because they've been in chronic pain and they may need that to actually get the pain under control. So I think the first step is to look at the individual pain plan and follow that, because it's quite frustrating for these patients when people don't know them or don't know the pain plan and start them off 20% of the dose that they need, and they're in agony. Failing that, if someone who doesn't come very often or is new, you would look at the WHO letter and your local policy, which is most likely to include opioids, non-steroidals and paracetamol, although obviously check for any hepatic dysfunction or renal dysfunction before just reflexively prescribing these. And it's very early on that they'll need a PCA. That's another reason we like to escalate early, because certain wards may not do PCAs. You may need to involve the anaesthetic team to set that up. Just to note that we never give these patients pethidine because there's increased risk of seizures with that. It's really important when you're prescribing opioids to remember the supportive medications that should form a part of the order set. So laxatives, you do not want patients getting constipated because that will just exacerbate the pain. You want them to not feel nauseous, so make sure you prescribe antiemetics and also antipyretics, because on high dose of opioids they can get quite itchy. I think it's great if you have non-pharmacological pain measures, so TENS machine or warm packs can be quite helpful. I did work in one place where they had a hydro pool, but I don't think that's so easily available, but that can certainly be very helpful. I'd like to stress that incentive spirometry is very important. So I want to see, once you prescribe the drug chart, that you find to put an incentive spirometer next to that patient's bed. It's a little sort of lung physio machine, and they have to take deep breaths in, and it helps to recruit the lower airways. And this is to prevent, hopefully, the development of acute chest crisis, which happens in the setting of an acute painful crisis, because these patients, when they're in pain, they hypoventilate, shallow breathing. That leads to them not really expanding the bases of their lungs, and that leads to the bottom of the lungs being hypoxic. That leads to sickling, and then it starts that cycle of an acute chest. The other thing is important to make sure you maintain normovolemia. So I would say previously people used to put patients with sickle cell on 1.5 times maintenance, but that's actually falling out of favour, because if they've got cardiac dysfunction, it's not good to flood them. Sometimes patients may have renal complications, so they can have very dilute urine because of the sickling in the kidneys. There is not that concentrating mechanism, so they may be polyuric, and that way they do need to have more fluid. However, on the other end of the spectrum, if they've had severe renal dysfunction and renal failure, they may not be polyuric and actually may be oligouric, and you don't want to flood these. So it's important to monitor the fluid balance and aim for normovolemia. Keep patients warm. You want to avoid cold because that leads to more vasoconstriction. And I must stress, make sure everyone's on VT prophylaxis, low molecular heparin, if there's no contraindications, and TED stockings, and close monitoring, so you want them somewhere where they can be monitored close to the nurse's station. So that's just summarizes vaso-occlusive management. Sort of the investigations you will send, you want to do a full blood count and reticulocyte count, looking to see the retic, if that's up, that coincides with the severity of hemolysis, although it's quite nonspecific. Same with LDH, looking at hemolysis and just your routine biochemistry, particularly paying attention to creatinine. If there's worsening jaundice, looking at if it's unconjugated, which goes with hemolysis, or if it's conjugated, which goes with hepatic dysfunction and CRP if there's infection. It's good to send a hemoglobin S level, a group and screed, and liaise with your blood bank early, because if a patient has any antibodies on previous screening, they need as much notice as possible to get appropriate blood in if necessary. If patients are febrile, just do routine cultures, blood, urine, copan, COVID. If the travel history determines that they're at risk of malaria, that's something you should screen for. And patients who've been on transfusions for a long time get iron overload and may need chelation. And chelation is a risk factor for eosinia. So any patient that has fever, diarrhea on iron chelation, you need to think of that organism. And similarly, amylase, because these patients can get pancreatitis. So if the clinical assessment is concerning for an acute abdomen, I would send amylase, and then chest x-ray and an ECG, looking for any lung infiltrates, ECG for any tachycardia, and so forth. So despite doing everything appropriately on the wards, poor Kofi now is febrile, he's tachycardic, blood pressure still okay, but up from before, and he's very tachypneic, and his SATs have dropped from 97 to 88% in room air. He looks terrible, he's very diaphoretic, and when you listen, there's reduced air entry on the right compared to the left. So we see this scenario quite commonly where patients develop acute chest crisis following pain, and it's hard to predict that will happen, and you try to mitigate that by doing the fluid management, antibiotics, PT prophylaxis, making sure they're doing the incentive spirometry, but this can happen. And the manage for this is that you have to liaise with your ITU staff, because they often need respiratory support. This patient in this case just needed some non-rebreathing oxygen, but actually did require BiPAP and a red cell exchange transfusion, which is the management. So you're taking out the sickle cells, replacing it with a 2 volume exchange to bring down the sickle percentage right down to less than 30. And we often get it less than 20. And because it's indistinguishable from pneumonia, you treat them with this macrolide, such as zithromycin, and a third generation cephalosporin, such as ceftriaxone or cefotaxime, depending on your local antimicrobial policy. So that kind of summarizes vaso-occlusive crisis and acute chest syndrome, which are the most common presentations on the acute medical unit. So I will go now to the outpatient setting and the sort of things you need to consider in that case. So I'm glad that Kofi, we followed him up. He's thankfully recovered from his pain crisis and acute chest. Now he's back at university, doing well, feeling much better, and he's come for his annual review. So I'm just going to go through how you review someone at annual review, because I suspect if you are in core medical training and happen to rotate through haematology, or in general practice you may see patients with sickle cell, it's a good idea to just go through how you evaluate patients and what sort of things they need to maintain a healthy life. So kind of the theme of the day is that sickle cell disease is more than just anemia, and there's lots of different factors to consider. So at the genetic level, the type of sickle cell disease you have can affect the phenotype. So HBSS and HBS beta 0 tend to be more severe than your beta pluses. We've got a bit of normal adult hemoglobin, and hemoglobin SC tends to be milder, with the exception of retinopathy symptoms. So generally, HBSS or HBS beta 0 are the worst in terms of clinical symptoms. You also assess the disease burden. So, are they having lots of crisis? Are they having lots of hemolytic anemia? And the complications, this is a big one. So people that are having recurrent strokes or acute chest syndromes, renal impairment and so forth, they're obviously going to be need to seen by other members of the multidisciplinary team, and that's going to have a significant impact on their social life and their ability to go to work and school. And I cannot stress how it's so important to have a care network and a support network. With any chronic disease, it's something that our patients, even when they're feeling better, they're never fully well, and just having a loving, supportive environment really helps them. And then sadly, it's just about access to care. There is a postcode lottery, unfortunately, where if you're in an area that has a hemoglobinopathy centre, access to trials, you may have a better experience than if you're somewhere in the country that doesn't have that set up. So these are sort of things to consider when caring for sickle cell patients. And I just want to talk about general considerations. So with any chronic patients, you're having a therapeutic alliance with your patients. It's really important to engage them in shared decision making, because an engaged patient is going to be better for them and also for you, because you'll be working together. It's really important to be empathetic, because some of our sickle cell patients have had terrible experiences. They've lost trust in healthcare systems, sometimes when they've been treated badly. And I think just listening and being empathetic and realizing it, it can be, people are really suffering when they're in pain, or they've had stroke, or they're having difficulties with employment. I'd like to just put it out there that I really detest the term sickler, and I'm not alone in this, because patients shouldn't be defined by the disease. So please avoid using the term sickler. And it's really important to manage these patients in a specialist hemoglobinopathy team, where they can access to a hematologist, a psychologist, renal, cardiac, respiratory, and so forth, and have that one point of access. Usually they have a specialist hemoglobinopathy centre who works in tandem and supports the local hospital. But it's really important that these patients are seen in a specialist centre. So my next slide is just some of the things that you have to cover. It's not exhaustive, but just gives you a flavour of the things that I would cover in an annual review. So neuro, you'd be asking them about pain, stroke prevention. So that's mainly medication. If they're having they may be on hydroxycarbamide for stroke prevention, or transfusions. Those are the modifying treatments currently. It's really important to just have an open dialogue about how they're coping with a chronic illness, and if they need any psychological support. Make sure they've been to retinopathy screening. Quite a few patients may have obstructive sleep apnea, so it's important to specifically ask about obstructive sleep apnea symptoms, because these patients, you want to manage that aggressively, because nocturnal hypoxia is associated with worsening clinical symptoms of pulmonary hypertension and acute pain crisis and acute chest crisis, because that hypoxia then predisposes more to vaso-occlusion. And then they will see the cardiologist and have echocardiograms for screening. If they're on iron chelation or they've been on a transfusion program, they need to be screened for cardiac iron at certain intervals. And it's important to address other cardiovascular risk factors, because with excellent supportive care, the life expectancy of patients with sickle cell is improving, and that's wonderful. But as with all aging people in the population, the increased risk of cardiovascular risk factors, especially with the Western diet of too much sugar, too much fat. So it's just about addressing smoking, diabetes, obesity, because they've already got sickling in the blood vessels, which is leading to a vasculopathic process, and then adding more vasculopathy is not a good combination. Then you're just with the GI about gallstones, if they need to be screened for any iron overload in the liver. Dealing sensitively with the GU renal system, so inquiring about priapism, any fertility, family planning, nocturia, because of the impaired kidney concentrating ability. If that's a problem, that can sometimes be something that people may not volunteer. You have to ask specifically, are they going up multiple times a night? And then screening the urine by doing a dipstick looking specifically at proteinuria, because fortunately some of our patients do end up developing even nephrotic range proteinuria and need to be started on ACE inhibitor and managed in conjunction with the nephrology team. You look at leg ulcers, because with chronic sickling and poor venous sufficiency, you can get leg ulcers. And then I don't quite understand the mechanism, but they're at risk of salmonella osteomyelitis. So anyone with fever and a bone pain, make sure you think about osteomyelitis. And unfortunately, avascular necrosis of the femoral head is a fairly common complication, and that needs to be picked up, because you don't want to avoid missing that, because that can lead to more in younger children, but leg length discrepancy and morbidity from that going forward. And then the therapies, hydroxycarbamide. If people are having frequent pain crises, more than 3 per year, you think about starting hydroxycarbamide. Certainly if they've had acute chest syndrome, folic acid, they should be on Penv, ideally for life, but compliance with that does wane. So, but it's really essential in the first 5 years of life. And if they're on a transfusion program, they may need to have iron chelation if their ferritin's rising or if they've had over 10 transfusions. As mentioned, patients with sickle cell can be prone to renal failure, and they may be on ACE inhibitors. Patients are black, and it's important to make sure we talk about bone health in general, so that they're on vitamin D. They should be on vitamin D supplementation. And if they want to travel, talk about going abroad, make sure they have antimalarials. And then I think it's really important to bring up clinical trials and transplantation, because I think the technology, particularly with gene editing, it's really exciting. And I think it's important to make sure you have a conversation with patients, and if they seem interested in actually positive in the possible clinical trials or curative interventions, we should definitely support them with that. And then you want to make sure that they're up to date with their vaccines, particularly in the adult population. Make sure they've had their pneumococcal vaccine, COVID, hepatitis B vaccine, they may need a booster. Any patient that's going to be on regular transfusions, we will screen for hepatitis and make sure they've had their hepatitis B vaccines, and make sure that they get boosters if the immunity is waning. And if they're going abroad, make sure they have travel vaccines and an annual flu vaccine. And just general things about inquiring about symptoms of anaemia, making sure you reiterate the signs and symptoms of aplastic crisis. So typically parvovirus B19 in patients with red cell disorders can lead to a red cell aplasia and really severe anemia. And that's typically they may have felt a bit flu-like and a bit ill, and then suddenly crash their counts. And that's usually the history, and more in kids. We see it run through families because they're all together and one sibling gets another one. So that's just one thing to always talk about that, and then reiterate that advice that if they have an infection or a fever, to go to hospital for antibiotics because of their impaired immunity due to poor splenic function. I also like to talk about health promotion. It's important with all patients to talk about making sure they're getting enough diet, exercise, hydration, and just inquire about, are they feeling supported socially, employment, education issues, so they have any issues with housing that we can help them with, because we're not just looking after the sickle cell, we're looking at everything holistically, because there's a complex interplay of these factors. It's important that we do follow a biopsychosocial framework to support our patients. And then with the annual review, we tend to send the following bloods. So full blood count, we take a film, if not always the film, but initially at the initial visit we do a film, your biochemistries, hematinics and ferritin. At the initial visit, so that's if a patient hasn't been seen in a sickle cell centre or a child, we do send a G6PD level, because a lot of patients from Africa who have sickle cell also co-inherit G6PD deficiency, and that combination, I mean sickle cell and G6PD deficiency, can lead to more hemolysis, but also that has management implications, because you're going to avoid certain drugs if they've got G6P deficiency. So it's important to know that. We also, we will tend to do hemoglobinopathy screen and track the HbS percentage, do a full hemoglobinopathy screen at the initial visit. We send virology, Hep B and C and HIV, because these patients may have transfusions. And then we always do a blood group and an extended phenotype at the initial visit. What that means is they look for a specific panel of antibodies and try to make sure that patients have blood that's matched to all these minor group antibodies. The reason for that is patients with sickle cell who get transfused are more likely to develop alloantibodies, and that's probably because the altruistic donors in the UK tend to be quite genetically different. They tend to be more white, Caucasian, so there's slight antibody difference between Black African and white Caucasian donors. So that's why we do see more rates of allo antibodies in patients with sickle cell who require transfusions than, say, transfusions in patients who are Caucasian for, say, cancer, for example. Okay, so the next scenario we're going to cover is the paediatric clinic, and it's pretty similar to Al, but there are a few specific differences that are important to cover, which I will go through. So we're going to meet the Olusola family. So Florence and Atkin, they're coming to the paediatric clinic with their 4-year-old son, Nathaniel, for his routine visit. And we're just going to go through how we counsel his parents. So just with the paediatric considerations, I think it's really important to educate the parents and caregivers, because they are going to be the advocate for their child. And I cannot stress that a key worker is really invaluable, and this is usually the role of a CNS. And also this is the same as well for the adult population. It's really important to have a CNS link, but particularly in children's, that is really invaluable actually. We want to involve key stakeholders like the nursery and school, making sure they're aware of sickle cell, if they need any education. Commonly, one of the nurse practitioners sometimes visit the school or arrange a consultation with the school nurse just to explain what is sickle cell, why when children go to school they need to maybe excused to go to the toilet because they need to pass urine more frequently, they can't run around too long and get dehydrated, and so forth. Just have those discussions, and it's quite helpful if they have a paediatric passport. And what I mean by this is just a little handheld document to say I have sickle cell, and that in their local hospital allows them to bypass A&E and get seen directly. So that's often works quite well. So just going through a systems review. So it's similar, you're going to go from head to toe basically, but a few differences. So in children, in terms of pain, particularly under the year of 1, they get dactylitis, which is a hand-foot syndrome with basically they get swelling of the digits, and that's a sign of vaso-occlusion in the small vessels in the fingers and toes. And actually that kind of heralds that they may be quite a severe phenotype of sickle cell. And patients that have presented with dactylitis, I might be having a conversation with a family start hydroxycarbamide when they're 9 months of age. So that's usually pain in a child, but then as they get older and can verbalise, we can talk about pain if they've complained with arm pain, being of school and so forth. Stroke prevention, so they're going to have cranial Dopplers, which we'll talk a bit more about in a moment. And then just in development, it's really important that they're attaining their milestones, that they're growing well. ENT, you inquire about any obstructive sleep apnea, because hypertrophic adenoids are quite common, and again that can lead to more hypoxia and more worsening pain. So that's important that we ask about that, and if necessary get them seen by ENT for intervention. And fortunately, sickling can sometimes lead to hearing impairment, so making sure parents don't have any concerns about hearing. Asthma is common comorbidity with sickle cell, and that needs to be managed, because anything that promotes hypoxia worsens sickle cell, and again acute chest syndrome. Usually in later childhood you'll be doing echo, and if they're on if they're on blood transfusions, then you need to look for iron overloading after a period of transfusion. And then in children, they're more likely to get splenic sequestration because their spleen is still normal size. It's only throughout childhood that it autosplenects, so it's usually in the first 5 years that they're at high risk of splenic sequestration, and they can just literally crash. So that's why we always teach parents how to fill the spleen and to seek urgent medical attention if they notice the spleen is bigger. And same with the liver, although liver sequestration is not quite as common. They can get gallstones. And then we talk about enuresis, usually from the age of 6, if children are constantly wet in the bed. It's really important to have a talk about that and warn the parents, because we need an empathetic and understanding way to manage this problem, because the kids can feel really upset and you don't want them to feel punished, because then that just really affects them psychologically. And then talking to the parents about young boys with priapism and how this is a medical emergency. As with adults, avascular necrosis is a problem, and it's important to detect that and intervene to avoid leg length discrepancy in children. So they may need, if it's quite bad, they have to have hip replacements, although that's not ideal. You try to defer that as late as possible, because hip prostheses have a limited, finite period of time that works. And similar to adults, you consider the same treatments, immunizations, and just again with general talking about symptoms of anemia, particularly aplastic crisis. So anyone with slack cheek, beware, and avoid pregnant women and so forth. And with the social, important to inform the families about the support groups, the sickle cell summer camps. I think it's really helpful with children in particular, and particularly adolescents, when they have that peer support and can interact with other children that are going through the same thing. Just something, when you see it and you know that you're not alone, that's really empowering. And nowadays, with the use of technology in the teenage and young adults, we can incorporate that to help them, particularly at time of transition, to take more ownership of their own care. So those are sort of the paediatric aspects that we address. Just in the first year of life, there's so much to discuss with the families, and it's important to try and give information in manageable chunks and rediscuss. But I think in the first year, the priority is to make sure you teach them splenic palpation and counsel them about the risk of splenic sequestration and signs of aplastic crisis and dactylitis. Those are the most common complications in the first year. Really stress to them that the penicillin prophylaxis is vital, because the life expectancy of sickle cell patients has really increased, and one reason for that is penicillin, because that's reduced the rates of overwhelming pneumococcal sepsis, which is the highest incidence of that is in the first 5 years of life. So that's why it's crucial that the first 5 years, please give the penicillin V prophylaxis. And just some practical considerations, they have to have it on refill with the GP because the liquid has a shorter half-life than the tablets. So when they get older, it's a lot better with the tablets because there's a much longer shelf life. Make sure that they see their paediatrician or their GP for the vaccines because they will need the meningococcal vaccines and the pneumococcal vaccines in addition to the normal schedule. And from 9 months of age, I talked to them about hydroxycarbamide because the baby hug study, one of the major studies looking at the efficacy of hydroxycarbamide in children, showed that from 9 months of age it was effective in reducing pain and has some other organ preserving functions. So it has been safe to use from 9 months of age. So just give them some information and revisit hydroxycarbamide. So the other thing that's pertinent for the paediatric care of a patient with sickle cell is stroke prevention. So they have transcranial Doppler ultrasounds, and this is done annually from the ages of 2 to 16 because this is the period where stroke risk is highest. Just to put it in context, a patient with sickle cell disease is 300 times more likely to have a stroke than someone who does not have sickle cell. So, it's really a major risk. So this is why we do the screening, and a screening Tesco, this is quite non-invasive, not painful, so it's perfect. So there are 2 things to look out for in the report. If it's conditional, so that's when the velocity is between 170 to 199, it's important that the child has a repeat in 3 months. But if it's abnormal, like very fast, more than 200, that's when you would refer them for a chronic transfusion program because transfusion reduces the risk of stroke. So this is about primary prevention, so which is ideal because anything that can stop the catastrophe happening is what we would like to do. So just a few considerations with chronic transfusions. So things we think about are top-up versus exchange. We prefer exchange because you're taking out blood, you're not just topping it up, so there's less iron overload. But the risks are that you have to get IV access, that's like a VASCAF, and they have to be big enough for that to accommodate that. Also, it takes a longer time, so trying to find availability, because one of the problems is capacity. It's not done everywhere, the exchange transfusion, so there needs to be in a specialist hemoglobinopathy team centre that has availability. So that is one of the rate limiting steps. Use a lot more blood when you do an exchange transfusion than a simple top-up. So that has issues, and as discussed before, patients with sickle cell disease do have a risk of developing alloantibodies, so sometimes we can get to a point where it becomes increasingly difficult to find compatible blood. The good news is that there was a Twitch study, a major study, looking at after having transfusions for a year with normalization to switch over to hydroxycarbamide. So in patients that have had at least a year of transfusions and their Dopplers have improved and they've had a normal scan, we could possibly at that stage consider switching to hydroxycarbamide. But obviously in patients that have had a stroke or their Dopplers aren't normalizing, or they've had an MRI abnormality, although not a frank stroke, we still need to continue with transfusions. So those are just the things to consider. And that's why logistically, although we'd like to do exchange for everybody, it's not always possible. Okay, and then just to finish off, I'll just go through sickle cell disease in the obstetric clinic and the approach and things to consider in that setting. So we're going to meet Mary. So she's a 32-year-old solicitor with sickle cell disease. She's been very compliant on hydroxycarbamide and actually has been quite healthy. She got married and wants to start a family. So we're just going to go through the counselling of women with sickle cell disease when they want to start a family. Quite a few things to consider. So unfortunately, there's a higher mortality and morbidity in mothers with sickle cell disease. So this can be related to sickle cell itself. So they're more likely to get vaso-occlusive crisis in pregnancy and acute chest and infection. And that makes sense because pregnancy in itself is a stressful physiological state, and people with sickle cell already have a stressed physiological state because they're anemic, their organs are working harder, so they're going to be more likely to get complications from sickle cell. Also, pregnancy itself, you're liable to get preeclampsia, and that's higher in black women. And black women with sickle cell is even higher because they already have vascular dysfunction. And then in the fetal complications are also increased because placenta function may be affected, so you may get IUGR, preterm labour and stillbirth, sadly. So those are the risks that we highlight to mothers, potential expectant mothers with sickle cell. So pre-pregnancy, you want to do a bit of groundwork to screen the partner and do prenatal diagnosis if the partner has also a hemoglobinopathy trait or it has hemoglobinopathy, to see if that patient, to see if the baby's at risk of a sickle cell disease. Sometimes we can offer chorionic villus sampling or amniocentesis, but it's really important that patients with sickle cell get a referral to obs-gynae very early on in order to facilitate this, should they wish to go down that line of having prenatal diagnosis. If a couple with have a child already with sickle cell disease, they can have pre-implantation diagnosis, but that is limited and has to be done in advance. So these are things to discuss. As we discussing this patient's on hydroxycarbamide, so any woman that wants to get pregnant 3 months prior to trying to conceive, it's important to stop hydroxycarbamide and any other teratogenic medications which may be needed, such as ACE inhibitors or iron chelation, and make sure they're taking their folic acid. So during pregnancy, you want to refer these ladies early to a high-risk pregnancy unit with expertise in sickle cell disease. Because of the risk of preeclampsia and just general vasculopathic processes, they're on aspirin. Once they're pregnant, we start them on aspirin. We try and avoid non-steroidals late in pregnancy and also early in pregnancy, just due to the risks of that. And it's really important because pregnant women are increased risk of having thromboembolism. But if you add sickle cell as a chronic medical condition, that increases the risk. So usually these women from 28 weeks gestation are on low molecular weight heparin. And certain patients will need to be transfused regularly in pregnancy. So if they're already on a transfusion program, or patients that previously been on hydroxycarbamide, so for Mary, I'd refer her to have transfusions because she's been on hydroxycarbamide. And then even if patients haven't been on a chronic transfusion program, if they're very anemic or have acute chest or a stroke, then they get a transfusion. Anyone with cardiac disease, you're going to transfuse them to avoid that physiological strain, really. And then same again with multiple pregnancy, just because that is more of a physiological strain, you want to make sure you support them with transfusions through that. Although obviously the caveats, if it's difficult to get blood, that will affect the clinical practice. And then they need enhanced monitoring, so they will need a viability scan, then different scans. So just in summary, from around after the anomalous scan at 20 weeks, they have monthly scans until 34 weeks where they're, after 24 weeks, it's going to be every 2 weeks and then weekly thereafter. And you also want to check their blood pressure and urine visit at these visits, particularly after 34 weeks because of the risk of preeclampsia. And then delivery and postpartum. The mode of delivery is based on obstetric indications. So another way to put that is that you wouldn't automatically do a cesarean section. They can have normal delivery, but if they're in distress, you do a cesarean section. Offer induction of labour at 38 weeks because you don't want these ladies going post dates, really, if you can avoid it. And we would prefer regional anaesthesia if they're having cesarean, so as to not put them under anaesthetic, and recommend fetal heart monitoring in delivery and they're increased risk of vaso-occlusive crisis. So just paying attention to make sure they're hydrated, that you've got blood ready in advance, they've got antibodies, that they're having their prophylaxis with low molecular heparin, and then just after they've finished breastfeeding, that's the point we really start hydroxycarbamide. So I realised that's quite a lot to cover on sickle cell disease, but these are my key points. That just remember that sickle cell disease is more than anemia. The clinical phenotype is very heterogenic, and it does require a multidisciplinary approach, empathetic communication, and patients really are the experts in their own disease because they know their individual pattern of sickle cell, how it affects them. Really, prevention is better than cure, and just knowing that sickle cell patients can deteriorate very rapidly, so it's important to be proactive and treat complications early and aggressively. And these are just some resources that you can find online freely if you want to do any further reading on sickle cell care in the UK. On my next slide. That's it. Thank you very much for your attention, especially in this hot weather. And any questions at all? Okay. Oh, you're welcome.
I just want to say thank you so much for doing this talk. It was really, really brilliant. I'll just leave some time just to see if any questions come through. But I'm just going to put the link to the feedback form in the chat as well.
Okay, thanks.
As well. Let me just check that goes through. And also just to say we do have another haematology webinar next week on the 26th, Tuesday, on anaemia as well, just in case anyone wants to sign up now if you enjoyed today. So yeah, any questions, anyone? You can just type it in the chat if you want. Okay, well maybe no one's writing today, but thank you. Thank you.
Well, thank you. I'm glad it was useful, and yeah, thank you so much for your attention.
And thank you again, Claire, for
no problem. My pleasure.
offering to do this talk. Okay, thank you, everyone.
Thank you. Have a good evening. Bye. Oh,
but just hold on. There's just one question. Yeah.
yes. So after surgery, so because of the physiological stress of surgery, they are more likely to get pain crises and acute chest syndrome. And actually, prior to surgery, we do tend to transfuse patients to really reduce the sickle cell percentage in a way to mitigate that risk. So yes, so pain and chest crises are what we worry about post-operatively.
Okay. Well, I think that's probably it then. So thank you very much everyone for coming.
All right, then no problem. Thank you.
Bye.